Hi and welcome to your next session with Plato Training. So for this session we're continuing to look at Unit 1, Dementia Awareness. Your aims and objectives for today are to explain why depression, delirium and age-related memory impairment could be mistaken for dementia. So dementia I have here some important words for this unit. This is going to relate to all of the work that you're doing. So dementia is a disability caused by diseases or conditions that affect the brain and that causes problems with the way the brain functions. The word symptoms means a physical or mental indicator of a disease or injury. Cerebral hemispheres, the key areas in the brain that are affected by the conditions and diseases that result in dementia, and they make up most of the brain. Depression, so severe dejection accompanied by feelings of hopelessness and being inadequate. Stress, being under physical, mental or emotional pressure. Delirium is mental confusion and changing levels of consciousness. And risk factors are the elements in someone's history or lifestyle that increase or decrease the chances of developing a particular condition. So these words relate to the entire unit, not just to today's session. So let's have a think about how we can understand what dementia is. So with dementia, it is not just one type of condition, okay? So dementia instead, there are over 100 different conditions that can cause the symptoms of dementia. So when we're thinking about the causes of dementia, you can also think of that as the types of dementia if you find that easier. So the causes of dementia that we're going to be looking at throughout this unit are Alzheimer's disease, vascular dementia, Lewy body dementia and frontotemporal dementia. So each of these cause dementia and they do it very differently. When you did your health and social care course, you would have looked at respecting and valuing service users as individuals. So let's just have a bit of a recap because this relates back to your course today. So what effects can respecting and valuing service users as individuals have on that service user? So it could help them to feel more confident in making choices for themselves. It could lead to more trusting relationships between service users and care workers. And it will help the service user to feel more in control of their own lives. When people know that they're being valued, their views and opinions are being listened to, they feel much more respected. And this relates to person-centred practice, which you should remember from your previous course in health and social care. So person-centred practice is about listening to a person's needs, their wishes, their likes and dislikes, and understanding the importance of meeting their individual needs which are right for them. In order to do this, we need to make sure that their needs and choices are seen as very important, because this otherwise would be very difficult to not having person-centred practice, where people could receive a service but it doesn't meet their needs. When you are completing person-centred care plans, you need to try and ask the person that you're caring for about what they want, because the person should always be at the centre of their care plan. This can be more difficult when you're working with people who may have dementia. In that case, you need to ask their families, their partners, their friends for more information, because the more information that you have on that individual, the more person-centred their care can be. You need to build a history of the person, especially if they can no longer tell you about who they are. So their families and their friends and any other informal carers that they may have could tell you about the service user. They can tell you about their likes and their preferences and maybe what they don't like and what their routine has been like throughout their life. What were they like as a child? Where did they work? Did they have any children? Do they have any grandchildren? Are they an auntie or an uncle? If you can find out about their history and paint a picture of the person that you're caring for, it's going to add value to that care that you provide that service user. So you can find out things like things that could trigger certain behaviours. So perhaps if you ask them if they had children, but they weren't able to have children, and it's a very negative feeling for them to be asked that question, we don't want to necessarily trigger something inside of them to make them unhappy. You could ask them about their routines, and if we change things, we don't want to that to have adverse effects. We need to use a preferred method of communication, because if we think about Makaton and British Sign Language that we looked at in your previous course, if we're using one instead of the other, it could be like speaking Spanish to an English person. Just because they've got the same alphabet doesn't mean the words are related to one another. So when you're doing your person-centered care plans, remember to use acceptable language when you're communicating. Remember to think about cultural and religious needs. Think about their well-being. Match them to a key worker that they could relate to. And make sure that you've got set routines and clear instructions, and that your communication is effective. So we're now going to have a look at, in a moment, depression, delirium and age-related memory loss. So although some of the symptoms cross over to match those of dementia, it's important that we continually see the service user as a person and not a set of symptoms of a condition or disease, because person-centered care should be putting the person at the centre of their care plan. So not looking at depression, not looking at delirium, and not looking at memory loss. Instead, we should be still focusing on the person. So when we're thinking about depression and dementia, depression disorder and dementia are common in older people, but they can occur separately or they can occur together. So diagnosis of either of these conditions can be very difficult for doctors because the symptoms are common to both disorders. They have very similar symptoms to one another. So when we have a look at depression symptoms, we have here sadness or feelings of despair, loss of self-worth, so worrying about being a burden, unexplained aches and pains, slow movement and speech, loss of interest in socialising or hobbies. Perhaps they've increased their use of alcohol. Maybe they've got weight loss or they're not eating as much. Maybe they've got some memory problems. Maybe they feel hopeless or helpless. Maybe they're neglecting themselves, like skipping their meals, forgetting their medication, or not wanting to get dressed and showered. Maybe they've got a lack of motivation and energy for those tasks. Or maybe they've got sleep disturbances, so maybe they are struggling to fall asleep or stay asleep. Maybe they're oversleeping or having daytime sleepiness. So these are all symptoms of depression, and older people can get depression as well. When we think about dementia, we looked at some of the symptoms previously, and here are some of those symptoms that are common to both dementia and depression. So loss of interest in normal hobbies, withdrawal or not wanting to join in social situations, being forgetful, so having memory lapses, sleeping too much, sleeping not enough, having difficulty concentrating on tasks. So I would like you to explain, for the first part of this question, explain why depression can be mistaken for dementia. So I only want you to answer the first part of this question, okay? So I just want you to focus on depression because we're going to continue and move on to delirium and age-related memory impairment afterwards. So I want you to explain the similarities of depression and dementia and how it can be difficult for doctors to perhaps diagnose that, so it could be mistaken for it. So I'd like you to link those similarities in. Please pause this video while you answer this part of the question. Delirium and dementia. So delirium means a sudden change of behaviour or rapid onset of confusion, and it causes both mental and emotional disruption for the service user. So delirium can happen because of a result of a urine infection, it could be alcohol withdrawal, or it could be recent surgery. The thing with delirium is it is very short term and it only lasts for a few weeks. I've witnessed delirium, and it is very hard to understand delirium until you've seen it yourself. So I witnessed a lady who had delirium as a result of a urine infection. She came into the hospital. I think she'd had a hip operation. She'd been on a surgical unit for quite some time recovering, and then she got referred to the elderly care ward while she was waiting for a care package to get put into place at home. While she was on the elderly care ward, she got a urine infection. To me, as a student nurse at age 19, I'd never seen anything like it. This lady was outspoken, she was quite rude, and her whole personality just seemed to change in a blink. It was so quick that it all happened. During visiting hours, what she did was she got herself up out of her bed and she went to the sink in the ward area where normally the nurses would wash their hands, and she started washing herself down below while singing "wash, wash, wash." And this was at visiting hours in front of the other patients and in front of their families, and it was really difficult to coax her away from that sink and back to her bed. But obviously she had no privacy and no dignity while she was doing this, but she wasn't aware of really what she was doing and where she was. Yeah, it was really difficult. So some symptoms of delirium: difficulty to think, difficulty to remember, difficulty to sleep, and difficulty to pay attention to anything. But just like with the lady that I just talked about for a moment there, it can be absolute confusion and a complete change in personality as well. But these symptoms are common for both delirium and dementia, so you can see how it could be difficult for somebody that doesn't know that person, hence thinking about person-centred care. You know, if you had a person come into your care home or into your hospital ward and they were showing those symptoms, you might automatically think, oh, they've got dementia, when in actual fact it's a short-term condition of delirium caused by a urine infection. So now I would like you to answer part 2 of that question to explain why delirium may be mistaken for dementia. Please pause this video whilst you answer that question. Age-related memory problems. So not all memory problems are related to dementia. Research shows that up to half of people over 50 will have some memory problems, but there are differences between dementia and normal age-related memory problems. Again, this is why it is so important that you have person-centred care plans and gather the information from their families, their friends and their informal carers so that you understand what is their normal. Because if over half of people, or up to half of people over 50 have some memory problems, we can't automatically say that somebody has dementia. The difference between these age-related memory problems and dementia could be that some people in older age might begin forgetting details of an event, whereas with dementia, the person might forget that the event ever happened at all. So an example of this could be like going to the cinema. A person with older age-related memory loss could forget what time they went to go see the movie at, whereas if a person has dementia, they might entirely forget that they even went to the cinema. So there is a difference between forgetting a detail and forgetting the event altogether. So we have some normal aging examples versus some dementia examples. So, for example, not being able to remember the details of a conversation or event that took place a year ago would be considered normal age-related memory loss. Whereas in dementia, the person might not be able to recall the details of recent events or conversations. Normal aging. Someone might not be able to remember the name of an acquaintance, whereas with dementia, someone may not be able to recognise or know the names of their family members. In normal aging, people might forget things and events occasionally, but with dementia, that would be more frequently. In normal aging, people might occasionally have difficulty finding words, so it might be that they are trying to think of a place name and it's not coming to them straight away. We all have those little lapses, don't we? And you think, oh, that's what it was. But with dementia, there could be frequent pauses or substitutions when finding words, so much more frequently the person is stuck because they can't find the words to say. With normal aging, people can be worried about their own memory, but their relatives aren't too worried about it. Whereas with dementia, it's the opposite. Your memory, your relatives will be very worried about your memory, but you're not aware of any problems yourself. So I would now like you to answer the final part of this question, age-related memory problems. So explain why age-related memory impairment may be mistaken for dementia. So now that you have come to the end of today's session, you should now be able to explain why depression, delirium and age-related memory impairment could be mistaken for dementia.